Good afternoon. This is for procedures 3 and 4. Guys, we're about to encounter the myelogram and the arthrogram procedures, so I thought it'd be a good time to do a recorded demo. And you were supposed to go over Sterile Technique in Introduction to Radiography and Patient Care with Ms. Dawn Ward. Thought it'd be a good time to review some of those principles and to show you some of the more common tasks that you'll be doing on the job as a radiologic technologist. One of them would be to set up a lumbar puncture or myelogram/arthrogram tray. It's basically the same tray. You use an LP tray for myelograms, arthrograms, and lumbar punctures. So it's pretty versatile as far as the containment. Now this is an older one. This is expired 1993. That's one of the things we would check before we started working with a sterile pack, especially a pre-manufactured one. So let's talk about surgical asepsis. And I am reading from an outline here. I know you can't see me. I'm off camera. We'll get to the myelogram tray in just a second. So what is surgical asepsis? It involves keeping the clinical setting and objects free from microorganisms as possible. So we want to utilize a set of rules and a set of instruments and accessories, and the objects, the instruments and accessories have been processed in such a way and stored in such a way that they are microorganism free. In other words, they're sterile. If we handle these in a certain way, we keep them microorganism free, and we don't introduce any foreign microorganisms to the patient during an invasive procedure. That's what Sterile Technique is all about, is following a set of rules and utilizing instrumentation and tools and accessories that have been prepared in a certain way such that the site of invasiveness, that is a needle or blade puncturing the skin, is kept as free of foreign microorganisms as possible, and even some of the native microorganisms as well. When you prep the skin with iodine, that's what you're doing, is removing the negative microorganisms. Okay? So Sterile Technique is used in operating rooms and in other conditions that are similar to surgical procedures. In the fluoroscopy room, most commonly, you're going to be encountering Sterile Technique with myelograms and arthrograms. Ladies, you'll also add one more procedure, and that will be the HSG, the hysterosalpingogram. Okay, that uses a slightly different tray from this one. This one is the one I'm going to demonstrate. I have never been in a hysterosalpingogram, so you're going to have to learn that from a female technologist on site when we get back to clinical education. It involves the use of physical barriers, gloves, gowns, masks, and drapes. Involves extraordinary control measures so that contamination does not occur. Okay, so there's a set of rules that everyone follows when we're performing a sterile procedure, and adherence to those rules keeps us in compliance and reduces the possibility of contamination. Okay? So how do we get this stuff? Well, it involves the use of autoclave to kill microorganisms from objects. Now, what is an autoclave? Well, an autoclave is a sterilization process. It's actually a machine. If you've ever been to a tattoo parlor, hopefully they had an autoclave. And it's basically just a sealed metal drum or sealed metal container that they can pipe hot steam into. So you usually have a compressor and a boiler and some kind of motorized pump, and hot steam enters the chamber after you have sealed it airtight and locked the instruments in, and you bathe the instruments in moist heat. And this is a registry question, your patient care and safety section. and patient education section, moist heat is the most reliable method of sterilization. Okay, you can also use the dry heat. You can bake things in the oven. That's what the oven is for in your kitchen, is to not only bake things, but to reduce microorganism counts in your food by subjecting them to dry heat over a period of time. So the food that you get from the oven is microorganism free for the most part, because you have baked it. Well, you do the same thing with sterile instruments, but the steam heat is just that much more efficient than the dry heat. The dry heat doesn't penetrate cracks and crevices as well as steam heating does. So the steam heating in an autoclave is more reliable. You can also use radiation sources, but those are much more expensive than an autoclave. You can use a radiation source to kill microorganisms. So you basically blast your instrumentation with very low kVp X-rays, high mass, low kVp X-rays, and that will ensure a lot of ionizations, and your single-celled organisms will succumb to excessive tissue damage. But again, that's more expensive than an autoclave. An autoclave seems to be the most efficient. That is, kills the most organisms for the least cost. That's our definition of efficiency. Okay, so you'll hear me talking about the sterile field. Basically, the sterile field is the usable space. We create a usable space within the exam room, whether it's the fluoroscopy room or up in the OR. Usually it's a table surface and the superior surface of the patient, whatever posture the patient happens to be in. Now, if the patient's prone, like for a myelogram or lumbar puncture, you're going to find that it's actually the posterior surface of the patient. Their lumbar spine and their back is going to be part of the sterile field. In addition to that, usually it's called a Mayo stand. It is just a stainless steel pan on a single support column, also made of stainless steel or aluminum or what have you. And it's got two wheels and it's got some forks on it, so you can park it anywhere, but you can also tip it just slightly and roll it around the room. And that's the Mayo stand or the tray table. Okay? I'm using a desk from a classroom right now, but it's just, I would say this is like 30% larger than a tray table like you'd see at a bedside in a hospital room. And it's probably about 3 times as large, 300% larger than a Mayo stand. But anyway, the sterile field is any area used when doing a sterile procedure. Materials used in the procedure are placed within the sterile field. So we're actually going to use the outer wrapper. This is wrapped twice. It's got an outer plastic jacket that we're going to remove. That's completely non-sterile. And then it's got the paper jacket that's actually going to form the bottom of our sterile field, because the inside of the paper jacket is sterile. Not with this particular one. This is the demo model that I've used over subsequent years, but we're pretending here. Okay. Area where the sterile field is placed must be clean and dry. So before I even set this thing down, I should be wiping off the surface here with my disinfectant wipes and then letting it dry by evaporation. Okay, don't come back through with another paper towel and dry it off because you're in a hurry. The paper towel has got microbes on it and you just recontaminated the surface. Okay, so let the disinfectant residue from your purple top wipes or your disinfectant wipes, let that air dry, okay, and then don't touch the surface again unless to open up the outer sheath, remove it, and place down your sterile pack. Okay? So that is the correct way to proceed. The area of sterility is covered by a sterile drape, okay? So unless the instruments are about ready to be used, I don't want to open this, right? So when doing a myelogram, let's say we're doing a lumbar myelogram, you would take your scout images, plain x-rays and MRI, then you'd go get your lumbar puncture tray and your contrast, okay? And an additional spinal needle if one's not included on the kit. You would send the scout images to the radiologist. You would tell the radiologist you'd be ready in 5 minutes, and then at the conclusion of that phone call, obviously the patient's been consented and all that stuff. That's when you would begin opening the tray and setting up the tray. And then after you set up the tray, then you don sterile gloves. You tell the patient to roll over prone, and at some facilities, you paint the injection area, the sterile. You set up the sterile field on the patient's back. You actually paint with iodine in expanding circles, centered at. You want to center at L4, L3, L4, but also L4, L4, L5, but also L5, S1, because those are the two most. They're going to try in L4, L5 first, but they like to have L5, S1 prepped. They like to have additional levels prepped as a backup in case there's too much scar tissue at the first attempted level, okay? And if patients had previous back surgery, there may be scar tissue present that could make it tricky to advance a spinal needle, okay? So the sterile field. Rules when dealing with a sterile field. All sterile equipment is double wrapped. So that's what this was. This was the outside wrapper. Okay, it told me that it was a myelogram tray, but largely this thing is considered inside and out non-sterile. Okay, and then it's got an inner wrapper, and you can see my fenestrated. Okay, guys, I'm back. I found a full kit. It's the same type of kit, same myelogram kit. I've also added a 20 cc syringe to my field, and I know I'm contaminating all over the place. Again, this is just for demo, okay? So I do have some sterile towels here, okay? You want to set those aside, okay? Don't want to cover up your syringes. You want the radiologist to see the syringes. Fenestrated drape again, and I know I'm running out of room over here, okay? Got some connection hoses. Long connection hose, small connection hose, and now I actually have 3. So I've got a frosted glass number 1, like I was talking before. So if I'm doing an LP and collecting cerebral spinal fluid to the lab, I would set these up with sterile gloves. So let me show you that part first. We'll put all this back up, and we'll just back up just 1 second. Let me move that aside. Bring that in just a minute. I think I showed you guys how to put on sterile gloves before. Maybe Miss Moore showed you guys how to put on sterile gloves. First thing you need to know is, well, second thing you need to know. First thing you need to know is, are you allergic to latex? If you're allergic to latex, you've got to seek out some non-latex nitrile sterile gloves. I am not allergic to latex, so I can utilize these. And then the other thing you need to know about sterile gloves is, what is your glove size? And this is usually trial and error. Most ladies, they start at about 5 for very, very small hands. So someone like Shinna, I would go for a 5 or a 5.5 if you can find it. And then as your hands get bigger and bigger, Tom, he's got a similar proportion to me. He'll probably be an 7.5 to 8 to 8.5. Probably Nick as well, somewhere 7.5, 8, 8.5. I'm an 8.5. I've got very large hands. You just have to figure out what your sterile glove size is, and then just remember that, especially if you do sterile procedures with any regularity. Okay. So when you open these up, you're going to open them up like you're reading a book, okay? And you should be able to read left and right. Right now, I don't know if you can see that. So for you, that would be like this, okay? But I'm opening them and about to put them on. Okay, so just like I was reading a book, okay, this is a sterile package. This is the outer, remember it's always double wrapped. So I would check to make sure that that was sealed. It was. I wrist rolled and dropped open the paper wrapping, okay, and then I folded that open like a book. I'm still not on the inside. See this down in here? All this, that's the sterile part, okay? So I still have the opportunity with these little flaps right here. I can open further and still not touch the inside with my fingers, okay? So I'll bring that apart, open that nice and flat, get those corners. Remember, this is just like any other sterile field. The tools and instruments on the inside, in the middle, are still sterile, okay? The outer border, what I've been touching and manipulating, all this out here, that's non-sterile, okay? Should not be reaching over a sterile field and touching a sterile object. Now, how do you get the glove on? Well, the first one you're gonna wanna do is your dominant hand. So you're gonna reach in with your non-dominant hand. And I want you to look, see how they're cuffed? And the cuff is actually rolled up backwards, halfway up the hand here. So that means that this here is actually the inside surface of the glove for my dominant hand. So I can touch it because it's gonna come in contact with my palm and my wrist region anyway. So I can pinch down here. I am not contaminating, lift it up in a single fluid motion, and then tuck your fingers in here like this, and with practice you can get this result. Now notice I have not touched the outside of that glove, okay? I've only touched the inside of the glove. Now the glove is still collared here, okay? But my fingertips and the working surface of the glove has not been touched, okay? So I've done that one right. Now I've got to do the second one right. Can I touch this? No, because then these two fingers will come in contact with my skin over here. Don't want to do that, okay? So what I want to do, remember this whole thing is sterile, I want to tuck my fingers, and I'll show you what that looks like. You see that? Tuck my fingers inside the cuff for the second glove, and then again, you position your fingers as such, and then just move them forward in a back and forth motion. And then as you get to the fingers, find the individual finger holes with the glove, pull. These things are very, very stretchy. The nitrile, not as much as the latex. Latex are extremely stretchy, so you can get, and then now both gloves are absolutely clean, still sterile. Now they're on my hands, and now I can do this maneuver. You see this? I can actually get the air bubbles out of the tops of the gloves and get those, get my fingers all the way in to the finger holes. And that's what you'll see the people wearing sterile gloves will do, okay? Will ensure, and then you can even get, it's very common, especially if you're new at putting these on, to get your pinky finger to go into the ring finger hole at the same time. Don't worry about that until you're at the final step. Then you can pull like this and actually pull your pinky finger back out and then get it into the correct position, okay? So if you've got two fingers going down one glove finger hole, don't worry about that till the end. You can sort that out after you have both gloves on, and you can redirect your fingers once they're inside the gloves, okay? Now, just so that I can get the myelogram tray back over here, I am going to contaminate just a little bit. Okay, so my myelogram tray, we're going to pretend that I didn't do that. The myelogram tray is here. My gloves are still sterile. Now I want to manipulate the equipment, okay? So what I want to do is, with a myelogram, fenestrated drape, you might be putting that on. Towels are in a myelogram or an arthrogram to wipe up moisture from, let's say you accidentally spilled some contrast, or there's some cerebral spinal fluid leak, or some lidocaine dropped onto the sterile field. The radiologist can, if it's excessive moisture, can dab that moisture up with the sterile towels. So typically, you as a technologist are not going to be utilizing the sterile towels. Just set those aside and leave those for the radiologist to use. Fenestrated drape, it really depends on your facility. Are you going to be painting the area of the patient's back or the area of injection with the sponges, or is that left to the radiologist? If you're going to be doing it, then you should be applying the fenestrated drape after you're done doing the painting. Okay? You may have to add additional syringes. If you're doing an LP, stand up your, and I did this wrong in the last tray, stand up your collection tubes so when the radiologist is utilizing the tray, they read from right to left, just like you're reading a sentence in a book. So it should, because it's going to be intuitive for the radiologist to grab the one that's lined up on the rightmost as he's working with the tray, or she is working with the tray. Don't have to be sexist. We do have some female radiologists. So there's an additional vial sometimes, and that's for additional cerebral spinal fluid, depending upon how many tests. Most of the modern kits have 4 tubes, not just 3. So there's an additional collection vial if the lab needs more than what is contained in the supplied syringes. Now this is a glass syringe. Again, way back in the day. Nowadays we're using the plastic drop-in syringes. You do want one with a lure lock for all your needles and filling. We've got some default spinal needles here. Typically, the kit is going to give you a 3.5 inch spinal needle. Sometimes they're going to vary in gauge. That is the diameter of the lumen. But they'll typically supply you with a 3.5 inch spinal needle. If your patient is hypersthenic, you might need an additional spinal needle. And typically those are stored. This, in fact, is, now this is a special myelogram needle. The thing about, I'm not sure if you can see that, it's got a blunt end, and the injection port is actually located on the side of the needle. So it's a kind needle, okay? And the kind needle, or the myelogram needle, is specifically for introducing or advancing into the thecal sac, because you don't want a beveled edge. The beveled edge may cut into a nerve root, okay? Whereas a blunted edge will just push the nerve root gently out of the way. You can actually pierce a nerve root if you have a beveled edge. So a lot of radiologists prefer the kind needle because then it reduces the risk of damage to the spinal nerves. Okay? Then you'll have typically a 1.5 inch 25 gauge or 23 gauge injection needle for the local anesthetic, which you'll also have to draw. Sometimes they have an ampule. I don't see the ampule, a local anesthetic, on this kit, but they usually supply a 5 cc syringe for that. Sometimes an ampule of the of the local anesthetic. You'll break the ampule with the gauze. So the ampule is going to be a sealed glass vial with a scratch mark at the neck, and you just put the gauze over the head of the ampule, and you kind of bend the ampule away from you, and it will fracture. The glass will actually break at that scratch mark at the neck. And then it's a single-use vial. Usually there's about 5 cc's of lidocaine in there. Don't draw it up with the injection syringe. Usually they give you a blunt drawing syringe, okay? So that's a blunted needle to draw. You should draw your contrast and your local anesthetic with a blunt tip needle, and then switch to the injection needle for the radiologist to utilize. Okay. So the last thing I want to show you with setting up the myelogram tray, yes, you're going to pour, sometimes they have a foil packet of betadine that you just tear open and draw into the reservoir. Oh, sorry, over here, reservoir, because we've got this little device here. Or sometimes it's a flip top cap and you'll need a non-sterile person to fill the reservoir with betadine, okay? Should fill it so it's just to the edge of, this is the sponge draining device. This pulls out, so I'll show you what that's for, okay? So imagine if this thing is got betadine in it, what I'm gonna do is I'm going to get my sponge soaked with the betadine soap, and then I'm gonna squeeze out the excess on this little raised surface here, okay? So when you see that, that's where the betadine goes, okay? Then if you're painting, if you are prepping the patient's back, or for an arthrogram, the patient's joint, okay? Always start at the middle and spirals outward. Never pull the iodine back into the center. So it's always an expanding spiral, okay? Keep the sponge in continuous contact with the surface. When you get out for myelogram, you want to make sure you're doing an oval, so you're doing multiple levels. For like a shoulder or a hip, you probably want a circle centered around the joint, where you think the joint is, probably about 6 inches out. Okay, so spiral 6 inches out, right? Pick the sponge up, throw it in the trash, grab the next one, soak, squeeze out the excess, start again from the center, and expanding spiral out, okay? Do you have to go counterclockwise or clockwise? It really doesn't matter, as long as you go the same way each time. So build a muscle memory with that, okay? Now, filling a syringe is usually, because I'm in sterile gloves and my syringes and my filling needles are sterile, the bottle is not sterile. So I'm gonna need a second person to pull this off. Now, I have done it by myself. I've set up a tray by myself, and here's the trick. The non-dominant hand, once you set up the whole tray and you're ready, you can put your needles together. So I've got one here. Let's see. Oh, don't want that. That's got thread and corruption on it. So I'm gonna hook this up to a 10 cc syringe, and that's a blunt fill needle, okay? I've got it uncapped, okay? And it's ready to fill. And let's see, do I have one more blunt needle? Yeah. So I've got this one here as well, and that's going to be for my contrast. Ooh, that's a fine one. That might actually be for local injection, okay? So let's say I'm trying to fill up my contrast for my arthrogram with this one, okay? But I can't touch the bottle yet because I've got both gloves sterile. This is what you're going to do. See? Touching the outside, so I'm still good, and then just pull. Come on. Ta-da! Now, my left hand, my non-dominant hand, is free to pick up the bottle. And I can do this, okay? Pick up the syringe with one hand. Oh, look at that. I can open it. Oh, we've got a jam in that needle. That's vacuum, okay? Or a jam in the syringe. Watch, see, look how dexterous I can get with this thing. Watch this. So I'm gonna do, don't recap your needles, ladies and gentlemen. I'm gonna pull up, this one has got some junk in it. It's making the syringe not function well. So I'm going to uncap this. This is just a safety there. And I'm going to, see, I did all that one-handed. Don't need two hands. So, and now that I've got the blunt needle in there, okay, let's just test the syringe, make sure it's going to be functional. No, also non-functional. So it's the needle is kind of jamming it. Okay. Do we have one more needle that doesn't have a bunch of crud and corruption in it? Maybe so. Patience is virtue. And then turn like that. Good. And then off you go. Is this one going to work? Still not. All these needles are jammed up. Don't recap needles, guys. Okay. So, since I can't show you that, I'm not going to show you pulling the plunger down. I'm going to put the blunt needle back on and show you how filling. So you can pretend my left hand is another non-sterile person. So the first thing, what I'm going to do is called presentation. Now, first thing is there's going to be an aluminum pull tab up here, okay? You don't pull the aluminum pull tab yet. What you want to do is show the sterile person the contrast, the name of it, and the strength. It's got to be the right strength. Check your facility protocol. Typically millilograms, you are using something like this, Omni 300, okay? Arthrograms, you might dip the strength of the contrast down a little bit, okay? Check with facility protocol, check with your radiologist what type of contrast they want to use. Also, 100 milliliters, that's way too much for a milligram. For a milligram, you only need 20 cc's. For an arthrogram, shoulder or hip, you only need 10 cc's of contrast, okay? And then for any joint smaller than that, you probably only need 5 cc's of contrast. But you want to present and show them that they've got the right strength of contrast and a sufficient volume. But again, you can get away with a 20 cc bottle if you have those on stock. And then, what's that there? Oh, that's the expiration date. So again, this is sterile contents. We want to make sure that the contrast is not expired, okay? If those two things check out and the sterile personnel agrees with the non-sterile personnel that this is in fact the right contrast for the procedure and it is not expired, that's the two particulars of the presentation, then you can hang the bottle facing the sterile personnel upside down and pop. What you do is you pop that ring, right, so that the rubber is exposed, and then you tip it upside down and just brace your wrist, right, and then angle it toward them and then raise it up to their eye level, okay? What they're going to do is they're going to come in like this, and they're going to try to hit the middle of that rubber, make contact, and then push. Come on. Oh, we are really jammed up. There we go. Push, and you gotta give it a little bit of force there. Push through that gasket, okay? And then they set the needle. See the tip of the needle in the bottle? They set the needle. Sorry, might have been too high there. They set the needle such that it's below the level of the liquid, and then they start pulling on the plunger of the syringe. And what that's going to do is it'll draw the contrast into the syringe. Once they see that they have a sufficient volume, then they hold the plunger where it is and pull the needle out in one swift motion, okay? Don't double clutch and stab. You're going to jab your non-sterile personnel with a needle, and that's just not fun, okay? No one wants a needle stick injury. Don't recap your needles, guys. I'm doing this because I need to teach next year's class with this monogram tray, so that's why I'm doing recapping. You should never be recapping your supplies, okay? Once a needle is exposed, it either needs to be utilized or it needs to be tossed, okay? Now, spinal needles, those are advanced by the radiologist. You don't have to worry about that. Admission of lidocaine, also the radiologist. You don't have to worry. Now, if you become a, what is that called? A radiology, I think it's called a radiology assist. if you become an RA, you will you'll do the myelogram for the radiologist. So you will be doing administration of lidocaine, local anesthetic, and advancement of spinal needles into joint spaces and thecal sacs. Okay, but for an X-ray tech, what I've shown you here is probably about the limits of what you'll have to do for preparation of myelography tray. And it might be that in some facilities, like I said, they don't even let the technologist paint. It's up to the radiologist to paint and prepare the sterile fields. In that case, just give them a reservoir full of iodine ready to go. But you don't have to necessarily scrub the patient down with the iodine sponges. Okay? That's all I got for myelogram setup and donning sterile gloves. I do want to show you guys a couple things related to the OR, but I'll wait and do that demonstration. Hopefully we can get back to, by the time we get to surgical radiography, I can come back to sterile field and show you some things about the sterile field when you're operating in the OR. Things related to the C-arm and also taking mobile radiography exams in the OR. So I'll save those for another recording.